Hello, ISC members. I would like to start this webinar. The title of this webinar is non-invasive risk stratification techniques for cardiac mortality. So I planned it. This time we invited 3 distinguished speakers. I think you can get very useful information regarding non-invasive risk stratification techniques. So this time all speakers are from ISE members. So let's get started. First topic is current status of T-wave alternans in risk stratification. The speaker is Professor Richard Verrier from Harvard Medical School, United States. Could you start your presentation, Richard? Yes, we can see. Yeah, please start.
Okay, thank you, Professor Ikeda. Ladies and gentlemen, good day. As Professor Ikeda said, my focus is on providing a state-of-the-art lecture on microvolt T-wave alternans and risk stratification. These are my disclosures. Dr. Nearing and I co-invented the modified moving average, which is licensed by GE Healthcare. We do not have revenue currently from the company. We have these research grants that have supported some of the work that's being presented. My objectives are as follows. I'll provide a brief perspective on microvolt T-wave alternans. Microvolt T-wave alternans is considered non-visible alternans when you inspect the basic electrocardiogram. So then I'll provide a description and update of the status of the 2 FDA cleared method which received CMS reimbursement. And then I'll highlight the findings from recent reviews and finish with discussing the novel findings which suggest that TWA may not only identify risk, but may be helpful in guiding medical and device therapy. So the origins of microvolt testing, quantification of very low alternans began in the 1990s. This was a preclinical study in large animals in which coronary occlusion and reperfusion and sympathetic stimulation were evaluated and tracked by complex demodulation. And the results look quite encouraging. This prompted a subsequent study in human subjects by David Rosenbaum in this important article published in New England Journal. And as you will see, this is the basic method in which a beat stream of 128 beats are acquired, then a time series generated, and a fast Fourier transform performed to look at the 0.5 cycles per beat. That's the spectrum of alternation behavior, and that's the principle of the so-called spectral method. And now, as you see in this early article, the results were quite encouraging. When compared to EP testing, there was a very close correspondence. That is, when alternans was negative according to this method, the survival was excellent in terms of ventricular tachycardia. But when it's positive, there was a shortened arrhythmia-free survival. This pattern parallel the results obtained from EP testing. Again, this was 84 patients. Results looked good and stimulated a decade's worth of research to follow up on these observations. Unfortunately, in large studies, in this case, the master trial, which involved about little over 500 patients, the results were negative. There was no separation in VT survival when the test was negative versus positive. And this was a major blow to the field. And it was subsequently the SCUD-HEF study and the ABCD study were also negative. I would say that it's important in all these large studies expose a flaw in the method. But the method required increasing heart rate to about 120 beats per minute by exercise or pacing and maintaining the heart rate. As many as these patients were on beta blockers, they decided to wash out the beta blocker to get the heart rate up. And then once the test was performed, they reinstituted beta blockers. And as beta blockers affect alternans as well as survival, this is a likely factor that accounted for the failure of the studies. The method has fallen into disuse and the company was dissolved. This is the second FDA cleared method, which Dr. Neri and I developed. It's called the modified moving average method. And instead of being a spectral based method, it's a time domain method in which it's assumed that during alternans there's a dichotomous distribution of beats, an A form and a B form. Templates are generated for the average A form and the average B form. And then they are superimposed into a QRS aligned template, and the separation in the T wave, the A-B separation, is quantified to provide a value for T wave alternans. This is the method that's used currently in treadmills and ambulatory ECG monitoring. This is a large study that was conducted in conjunction with our Finnish colleagues, Professor Nieminen and Huikuri, involved 1,000 patients, 1,037, which is twice the size of the master study. So it's a large study. And what this investigation showed is in the Kaplan-Meier curves, there's a highly significant separation between those who succumbed to sudden death and those who didn't. So when the cut point of 65 microvolt is employed and this QRS, automated QRS template is provided, it is utilized, the relative risk was 7.4 of sudden death, highly significant. And I would say that subsequent studies involved up to 3,500 patients. So very robust finding in terms of predicting sudden death during an exercise test. This is a view which I'm proud of that I did with my distinguished colleague, Professor Ikeda, in which we reviewed the literature on application of microvolt alternans testing in ambulatory ECGs. And by the way, the spectral method cannot be used with ambulatory monitoring because it requires fixation of rate. We reviewed the literature on risk assessment and the use of microvolt alternans in guiding therapy and discussed mechanisms as well. One of the more important studies is one conducted by Dr. Sakaki and Professor Ikeda's group, involved nearly 300 consecutive patients with ischemic and non-ischemic etiology with ejection, left ventricular ejection fraction in a range of 34%. There were 27 cardiac deaths and 5 witness deaths. Here again, the results were quite impressive for both ischemic etiology in the upper level and non-ischemic etiology at the lower, the B panel. There was a major separation in survival and at a cut point of 65 microvolts. Hazard ratio was 19 for ischemic and 12.3 for non-ischemic. So this is quite encouraging in terms of using modified moving average for identifying risk of sudden death in patients undergoing routine ambulatory ECG monitoring. Also in this review, we developed what we refer to as a ladder of risk, covering a number of different conditions. And the actual, and as you see with this method, it's not simply identifying positive or negative, but rather what is the value of alternans in microvolts. And the conservative cut point is abnormality is 47, 60 or 65 is considered severely abnormal. Looking at this cut point, in patients with stable coronary disease, the alternans level is relatively moderate. During cardiomyopathy, patients with non-ischemic origin, particularly, they traverse this the line of abnormality. This is from the TRAMI study that I know Dr. Takahashi will be discussing baroreceptor sensitivity. We found, in fact, that was our first clinical study with microvolt alternans using modified moving average. Those patients who had subsequently sudden death after their MI had a high level of alternans. STEMI yielded the highest level of alternans and predicted when the alternans level was high, predicted VT. And this was also an important finding that in patients who underwent dialysis had exceptionally high levels of alternans. And it's known that patients who have undergo dialysis are at high risk for dying suddenly. This brings another important discovery that if you combine the modified moving average method of T-wave alternans and heart rate turbulence, which will be discussed by Dr. Bauer, that independently, HRT is a very important tool, very valuable tool. If you combine the two, Dr. Ashida and Dr. Ikeda's group showed there was the maximum separation in terms of cumulative probability of survival. So this autonomic measure thought to be an indicator of baroreceptor sensitivity and cardiac electrical stability are very helpful in predicting sudden cardiac death. I want to bring attention to the fact that the refined ICD trial is ongoing, and the enrollment will, the projected enrollment will be 1,000 patients. And in this initial report on 600, nearly 700 patients, the presence of both abnormal MMA and HRT identifies risk with 9.6-fold higher risk for sudden death when it's positive. The ultimate goal is to determine whether TWA and HRT guarded ICD implantation improves survival. I would draw your attention to this important paper by Takasugi, in which they studied patients with long QT syndrome, and it's well known long QT syndrome has macrovolt alternans, but they showed that if you employ microvolt alternans, you can identify more patients at risk, that the subtle levels of alternans are more prevalent in long QT than expected, and is strongly associated with a history of Toussaint de Pointe. And they also found that using precordial lead helps to enhance the yield of T-wave alternans versus simply limb leads. This is a recent study published in heart failure of heart failure patients. It's a pilot study in which multiple parameters, including T-wave alternans, were investigated, and it was impressive that heart rate turbulence slope was improved by chronic vagus nerve stimulation in these heart failure patients. There was a sustained reduction in T-wave alternans, and a number of patients with VT was reduced. And you can see here now the familiar templates. And this patient, for example, is 97. After 1 year VNS, it's 42 and 36. So here's a device therapy where alternans appears to correlate with the positive results clinically. And this is simply ejection fraction, 6-minute walk test, and your association class, all improved by VNS therapy. And we believe that based on large numbers of experimental studies, that the basis for this reduction in alternans is increased anti-adrenergic action, improvement in baroreceptor sensitivity, and actually effects of structural changes in the myocardium, reducing glims, including reducing death of myocytes and a reduction of inflammation. And it's interesting, in this penultimate slide, this study by Kenton involved 130 patients studied for 2 years of exercise rehabilitation versus not, and a large reduction in alternans. And it's known that exercise, of course, improves vagal tone, and this way may well be a factor for the positive reduction in alternans. So in conclusion, microvole alternans as a strong scientific underpinning. We didn't have time to cover this, but more than a decade of research suggests that reduction in temporal spatial dispersion and improvement in calcium cycling are responsible for alternans, and that it's a versatile tool. Not only can be used in ambulatory ECG monitoring. We've shown recently with patient-friendly EKG patches that alternans can be detected using these devices, of course, during exercise tolerance testing, and then combining these two is particularly effective. And the results suggest that not only can alternans identify risk, but may be helpful in guiding therapy. Thank you so much for your attention.
Thank you, Richard. Do you have a question or comment? If you have a comment or a question, please release mute. So, Richard, I have one question. So, regarding the methodology of TA alternans, there are two methods. One is a spectral analysis, and another is a time domain analysis. Could you explain about the predictive accuracy of two analyses in risk stratification?
Well, the spectral has been very strong, except that it has the problem of requiring fixation of heart rate. And most of the patients who have that post-MI can't get the heart rate up. And so it requires beta blockers to be washed out, which really is disadvantageous in terms of accuracy. And since with the modified moving average, we don't require rate fixation, that alleviates that problem. And as you saw, the odds ratio are in the range of somewhere between 6 and 10, and in your study at that level. So that leads to a high sensitivity and specificity of the modified moving average method. While spectral is no longer in use, I think that, and also modified moving average is available by GE Healthcare. I think the results are very promising, and that we can turn to the question of, can we guide therapy? And that's the frontier.
Okay. So from our audience, Dr. Debbie, do you have questions?
Yes.
Yes, please.
Richard, I noticed in one of your slides that there was also a QRS alternans. Can you comment on the importance of the QRS alternans versus T-wave alternans, or the dissociation of the two?
Yes, that's an excellent question. In the initial study by Rosenbaum, they saw some alternans, but subsequently focused entirely on T-wave alternans. We do notice QRS alternans, and I think that question needs to be revisited. My own feeling is that in certain conditions like heart failure, that QRS alternans may be prevalent and be useful to analyze. And our method of modified moving average can be applied to the R wave. So this question is excellent, and that issue needs to be revisited. And I sense, maybe with ischemia, it's mainly T-wave alternans that occurs, but, and this may have implications in terms of cardiac resynchronization therapy, which may reduce, and this is partly a speculation, we have some evidence, QRS alternans. So very, very good question, very important. The field should focus, not go back to look at QRS alternans.
Thank you.
Okay, so any questions or comments? Okay, thank you very much, Richard. We will move to our second topic. The next speaker is Dr. Axel Bauer. The title is Fractional Use of Heart Rate Turbulence in Risk Stratification. But we will focus on more periodic repolarization dynamics, so-called PRD. Did you have a presentation, Axel?
Yeah, thank you very much indeed for the invitation. It's a pleasure to be here, at least virtually. And I have a difficult topic because I have to split my time into two separate talks, actually. In the first minutes, I would like to give you a brief overview of heart rate turbulence, while in the second part of the talk, I would like to introduce periodic repolarization dynamics and inform you about the latest findings. So as you all know, heart rate turbulence practically is a measure of sinus node function, which is influenced by sympathetic and vagal influences. Periodic repolarization dynamics, in contrast, is a marker that most likely captures sympathetic influences on the level of the left ventricular myocardium. So in the first part, I would like to focus on heart rate turbulence. This is a slide which some of you might already know. It's from a consensus of a ISE consensus document summarizing the phenomenon of HRT. On the left-hand side, you see a normal response of the cardiovascular autonomic system to a premature ventricular beat. You see here the average pattern of R intervals in the red curve here prior to a VPC. Here you see the coupling interval, here you see the compensatory pause, and after the compensatory pause, you typically see a biphasic short-term oscillation of RR intervals. As you see from the orange curves, the single patterns largely variate. In high-risk patient or patient with abnormal cardiac autonomic function, the typical biphasic response is blunted. When the phenomenon of heart rate turbulence has been discovered, it has not been known what is the underlying mechanism. Now it is very clear that it has something to do with the baroreflex and the corresponding pattern of arterial blood pressure. You see the red curve here shows in parallel to the R intervals, the blood pressure pattern, which is very similar. And it is assumed that the brief fall of arterial blood pressure in response to the irregular contraction of the heart by the VPC leads to immediate vagal withdrawal, which leads to turbulence onset. Turbulence onset is the immediate R interval shortening. In the response, the sympathetic nervous system reacts and the arterial resistance subsequently increases. leading to a re-establishment of vagal function and leading in turn to turbulence slope, which is the second phase of heart rate turbulence. So in summary, this is a complex interplay between the vagal and the sympathetic nervous system, which lead to a normal heart rate turbulence. If one of the systems is abnormal or the function is not normal, then the heart rate turbulence phenomenon cannot appear. What is required to assess heart rate turbulence? Usually it is required to have a full 24-hour Holter recording. One lead might be enough because you only need to look at the R intervals practically. There needs to be a resolution of 128 Hertz, and you need sinus rhythm in order to detect this phenomenon. It's not possible to use AFib or paced rhythms. And importantly, WPCs that are used to calculate heart rate turbulence need to fulfill certain criteria. First, there should be a certain kind of prematurity. Then there needs some kind of compensatory pause. This is to ensure that the WPC really induces some turbulences in the blood pressure. And this is also really important. There needs to be a certain amount of R intervals undisturbed prior and following WPCs in order to detect the phenomenon. And then there's some aspect which is really important in my opinion. It's regarding the measurement of signal averaging. Here you see, for example, a patient with single types of responses to single ventricular premature complexes, and as you can see, the single responses vary a lot. And some people have tried to estimate turbulence onset or slope from singular WPCs and then average the turbulence onset and slope measurements, which is not useful. You need to average the single responses. Here you see a typical 24-hour pattern in order to get the real the real averaged and typical response to WPCs, free of artifacts and other sources of heart rate variability. So if you want to compute heart rate turbulence, then there you assess turbulence onset very briefly. This is just the ratio between the two R intervals following the WPC and the two R intervals preceding the WPCs. And turbulence slope is the maximum average slope that can be placed over a sequence of 20 R intervals following the WPC. The cutoff values have been developed for heart rate turbulence, and typically turbulence onset is defined as abnormal if it is above or equal than 0%. This means that there's no kind of acceleration after the WPC in the signal average tachogram, and abnormal turbulence slope is defined if it's below 2.5 millisecond per R interval. And again, I think this is really important. It has to be calculated from the signal average tachogram. Many patients do not have WPCs, and it is important to recognize that these patients are attributed to the low risk group of patients, at least in post-MI patients. This is the way the prospective trials have been performed. You see one of the seminal trials, the first prospective validation of heart rate turbulence, and you see patients with both abnormal onset and slope have the worst prognosis compared to patients with normal heart rate turbulence or patients without WPCs. This slide shows that heart rate turbulence is a strong predictor of mortality, total mortality in post-infarction patients across the different treatment areas, MPIP and IMIAT were the pre-lysis, lysis and lysis area, while ISA or HRT was performed in the primary PCI era. Now I would like to briefly capture or inform you about paradigmation dynamics, which is a different type of biosignal algorithms than those assessing sinus node function, and shares some similarities to T-wave alternans, which we have heard before. This is a slide, Richard will know this, of course, because he wrote the paper at that time, showing that the sympathetic nervous system is strongly involved in the genesis of malignant arrhythmias. And the anatomical structures that are responsible for the efferent sympathetic nerve traffic to the heart are the sympathetic ganglia. And one of the features of the sympathetic nervous system is that the nervous bursts are organized in some kind of low frequency patterns of about 0.1 Hertz or lower. And as the sympathetic nervous system in particular is influencing the cardiac ripplization phenomenon, we hypothesized that phasic sympathetic activation in the low frequency component should result in periodic changes of cardiac ripplization that in turn should be detected or should be detectable in the T wave on the surface ECG. This was the hypothesis of PRD. But it's important to recognize that there are certain criteria important to assess PRD. First, you need a three-dimensional representation of the T wave, and usually we recommend to do Frank Leeds configuration or 12 leads configuration that can be later on transformed into an orthogonal leads configuration. Then the recording should be standardized, usually supine position, resting conditions, quiet conditions. You can also use the night hours of a auto recording if no standardized recordings are available. In some of the prospective cohort studies or retrospective cohort studies, we applied PRD to the night hours of auto recordings, which works rather well. And of course, the ECG should be of good quality and preferably have a resolution of at least 1 kilohertz. It's an open source software, the algorithms have been published, it's not patented, and so forth. So I would like to briefly show how it's calculated. In the first step, we, starting from a three-dimensional representation of the T wave, we calculate a three-dimensional vector which is representative of the main direction of the T wave in space. This is nothing unusual. Many people have done this before, but now please look at the T wave vector in a patient in supine position, resting condition. The T wave vector is changing. It's changing from beat to beat. The yellow angel here shows the amount of changing. It's the dt, we call it the variable dt, and below you see the dt signal over time. And you can clearly see there is some kind of low frequency pattern in the dt vector or the changes of the T wave vectors over time. You can quantify, of course, this curve in many ways. In the similar publication, we recommended spectral wavelet analysis and just calculated the amount of spectral power, wavelet spectral power in the frequency range below 0.1 Hertz. This was defined as PRD. And very briefly, I would just focus on the mechanisms. I have to be brief because of the sake of time. We have shown in previous work that PRD is independent from underlying heart rate variability. This was done in peace studies. So this is not an epiphenomenon of heart rate variability. This is an own phenomenon in our opinion. It's autonomous from respiratory activity. This has been shown in the swine model. You can clearly show by cross-spectral analysis that these oscillations are not directly related. PRD is clearly enhanced by extrinsic sympathetic activations such as tilt testing or exercise, and in turn can be diminished by beta blockers. And the people from the University of London, Professor Taggart and his group, have shown in really comprehensive and well-designed studies, computational models, that PRD is linked to efferent phasic sympathetic activity. Currently in Munich, we are doing some animal models and where we try to elaborate on the PRD phenomenon. Here you see, for instance, a swine 3 months after myocardial infarction with clearly increased PRD compared to baseline. Now we come to risk prediction, the potential prognostic value of PRD in heart disease. On the left-hand side, you see a surviving patient. On the right-hand side, you see a non-surviving patient after myocardial infarction. The right patient died 3 months after myocardial infarction, and you see that in the right patient, there's also a low-frequency pattern, but the amount of low-frequency pattern is much more enhanced. PRD is increased, and this is typical an abnormal phenomenon. PRD has been, in the first study, has been tested in acute myocardial infarction patients. This is a Munich cohort, a 908 patient. In that cohort, we dichotomized the patients according to the fourth quartile, and you here see the patients with the upper fourth quartile of PRD, and you see these patients have a much worse prognosis in terms of total mortality compared to the patients with PRD less than 5.75 dex square. It is also working in chronic post-MI patients. Here you see the result of a blinded validation study in the MADE-2 population. This has been performed by the group in Rochester. The mean ejection fraction is in the MADE-2 is roughly 25%, and you see that PRD, particularly the upper quartile, is a strong predictor of mortality. But very interestingly, if you look at the type of deaths which are predicted, you will see that PRD is a strong predictor of sudden cardiac death in the MADE-2 population. So this study nicely shows that increased PRD is really linked to malignant arrhythmias and appropriate ICD shocks in this cohort. Recently, we have published the result of the EUR-CERT ICD study. This is a multi-center, non-randomized prospective cohort study conducted in 15 European countries, led by Professor Zabel from Göttingen. You see, we included many countries with different types of ICD implantation policy, and included 1,371 patients with ischemic and non-ischemic cardiomyopathy and ejection fraction below or equal to 35%. And one of the work packages in this EU-funded trial was PRD. And we could demonstrate that there is a relationship between the level of PRD at baseline and the mortality benefit by ICD implantation that can be achieved. So this was a non-randomized trial, and this has been done by propensity matching. So there are some statistical issues which need to be recognized. It's not randomized, but it was a significant finding that PRD was first linked to appropriate ICD shocks and predicted somehow the mortality benefit by prophylactic ICD implantation. And we therefore believe that PRD might be a suitable tool for personalized treatment decisions in patients who are considered to be potential candidates for ICD implantation for further for optimized decisions. Very recently, we presented the results of our SMART-MI trial. SMART-MI focused on post-MI patients with preserved ejection fraction above 35%. And in this study was conducted in Germany and Austria, and we screened 1,305 patients and performed biosignal analysis in these patients by a 20-minute ECG. We implemented a core lab, and we assessed PRD and DC. The DC stands for deceleration capacity, and if one of these markers was abnormal, the patients were considered to be at high risk. And we enrolled 400 high-risk patients, which were then randomized to ICM implantation or conventional follow-up. ICM stands for implantable cardiac monitors. In this study, we implanted Medtronic Reveal Link recorders, which were connected to the CareLink system. And we looked for predefined serious arrhythmic events. And you see here that in the continuous telemonitoring group, we were able to collect or to assess more serious arrhythmic events than the control group. This was somehow expected, but the amount of detection was really surprising. Roughly 40% of the patients experienced serious arrhythmic events in this group. Serious arrhythmic events were somehow heterogeneous. We focused on atrial fibrillation, on higher degree V block, and on sustained and non-sustained ventricular tachycardias. And all of the single components were much higher in the ICM group than in the control group. Interestingly, the mostly asymptomatic arrhythmic events in this group predicted major adverse cardiac and cerebrovascular complications in the following phase. In both arms, we had 25 and 26 MACI events, and the detection of asymptomatic arrhythmic events was capable of predicting subsequent MACE with a high sensitivity and a high positive predictive accuracy. And I believe that this is encouraging, that telemonitoring might be useful in the future to better risk stratify patient in a continuous way. So not that we just say at the beginning, after the infarction, the patient is at high risk or low risk, but that if we can perform a continuous way of risk prediction, and the patient can switch between risk categories during follow-up. I think this could be an interesting way to personalize treatment decisions in the future. So what I would like to conclude, and I hope I'm still in time, HRT quantifies the biphasic short-term oscillation of R intervals following spontaneous VPCs. HRT is mainly due to a baroreflex mechanism, although other mechanisms might be involved. But a normal HRT requires an intact interplay between both branches of the autonomic nervous system. Blunted HRT is a very strong predictor of overall poor prognosis. Although it has been invented 20 years ago, it's still, in my opinion, a very robust and very strong predictor of mortality. PRD captures low-frequency oscillations of repolarization instability. I did not discuss the relationship to T-wave alternans, which is very interesting, of course, and most likely it is linked to phasic afferent sympathetic activity. And clinically, PRD can be used as risk predictor in ischemic heart disease and is particularly linked to arrhythmias. And I think this is important in contrast to other autonomic markers, that we have a link to arrhythmias. Thank you very much.
Thank you very much, Axel. So do you have comments or questions? Any comments or questions?
I do.
Okay, Richard.
First of all, my compliments, Axel. This is really elegant work. I was impressed in the beginning with HRT, and now you have a new marker that is also very promising, PRD. So again, this is an important advance, shows practical applications. I have a couple of quick questions. Are HRT and PRD complementary? So in assessing patients, because you get the same from the same recording, that's the beauty of it. You could do this on EKG patches, for example. I think they are heading to replace largely standard Holter monitors. So you could do this on an EKG patch. So number one, are they, do you have evidence that they are complementary or pretty much have equivalent predictivity? That's a very practical issue.
So heart rate turbulence and T-wave alternans, as well as PRD, are complementary as they capture different facets of the autonomic nervous system. In smart MI, we use deceleration capacity, which is also a marker of autonomic global tone, and assesses the sinus node function as heart rate turbulence. And in our prospective studies, we only had 20-minute ECGs, and therefore it was not possible to calculate HRT, which might be a limitation of HRT. In EU-CERT ICD, we had 24-hour ECGs, but in EU-CERT ICD, HRT was not so predictive compared to other markers, which might have different causes. So I can show no evidence. Heart rate turbulence and the PRD, I think, are complementary.
Okay, so next, Dr. Julia Ramirez, please have a question.
Yes, hello. My question was if you had tested the PRD in the general population.
Yeah, we have some preliminary results of the Naohiko cohort. The Naohiko cohort is a population-based study in Bavaria, and one part of the population of the core of the surveys had routine Holter recordings. And in roughly 600 patients, we calculated PRD, and over a follow-up of 10 years, PRD was predictive of total mortality. But I cannot tell you or cannot claim that these are healthy persons because they might have underlying heart disease. So it was a population-based study, and it was predictive. But if it's predictive really in healthy patients for future events, I don't know.
Thank you.
So
oh, sorry. Yeah.
Okay, Dr. Devi, please have a question.
Yes, thank you, Dr. Bauer. I see a lot of similarities in instrumentation and the type of test between PRD and late potential signal averaging. Can you comment on the combined result or combined clinical predictivity of the two?
I hope that I'm answering your question correctly. I don't think that signal averaging and PRD is similar. First, PRD assesses dynamic changes, periodic changes, and is not assessing small changes on average. Signal averaging has been mainly used to detect after depolarization changes, while PRD is clearly focused on repolarization. So I don't think that they are related. It might be interesting because I also like your first question to Richard. You could try to use the same technique of PRD on the QS complex. Yeah? And we did this, and there's also some kind of oscillation, which in very preliminary results was not so predictive as those oscillations of the T wave. But we have not completely understood this type of phenomenon.
Mm-hmm.
So this is my conclusion for this. Regarding signal averaging, in our studies of modernly treated post-MI patients, we found it not really predictive anymore. We published a study, this is already more than 15 years ago, where we showed that signal average ECG lost its predictive value. I think this was published in the European Heart Journal 2006 or something. But maybe in other settings it might be useful, for instance in low EF patients or whatever. So I'm not so experienced in signal averaging ECG, but I think it's different type of looking at phenomena.
I know, I was just struck by, it's kind of the same test, right? Kind of 20 minutes supine, and you sit still and you collect ECG.
So from the setting, it might be similar, yeah.
From the instrumentation point of view, that was I was struck by that. Thank you.
Okay. Okay, Axel, thank you very much. Very nice presentations. So let's move on to the third topic. The title is Recent Advances of Baroreflex Sensitivity in Clinical Practice. The presenter is Professor Naohiko Takahashi from Japan. Could you start your presentation, Naohiko?
Thank you. I will share the slide.
Mm-hmm.
Can you see?
Yes, we can see. Yeah, please start.
Okay. Today I will talk the recent topic of baroreflex sensitivity in clinical practice. This is my COI. Firstly, I would like to introduce the results of a TRAMI study which estimated the BRS in patients with recent myocardial infarction. As shown here, TRAMI study is the multi-center international prospective study enrolled 1,284 patients with a recent myocardial infarction. The mean duration of follow-up was 21 months. Of these patients, 5.1% died and 5 had cardiac arrest. 21 of the 65 deaths were due to non-cardiac causes. So, as shown here, 2-year mortality was higher among patients with BRS below 3 here than those with well-preserved BRS. So, the authors concluded that TRAMI provides clinical evidence that after myocardial infarction, the analysis of vagal reflexes has significant prognostic value independently of ejection fraction and ventricular arrhythmias, and that it significantly adds to the prognostic value of heart rate variability. Here, it is noted that 55% of deaths were sudden. So the sub-analysis was performed focusing on the arrhythmic deaths and ventricular arrhythmias. The result was published in Circulation 2001. The objective of the present analysis was to examine the role of both of BRS and heart rate variability in modifying the risk for cardiac and arrhythmic mortality associated with runs of non-sustained ventricular tachycardia in the entire population by TRAMI who had a myocardial infarction and in the subgroup with depressed ejection fraction. In this study, the combined endpoint was set at arrhythmic death and sustained VT. This slide shows the results. Among patients with LVEF less than 35%, despite the absence of non-sustained VT, depressed BRS predicted high mortality as shown here. So it is concluded that BRS and heart rate variability contribute importantly and additionally to risk stratification. Particularly when EF is depressed, the analysis of BRS identifies a large number of patients at high risk for cardiac and arrhythmic mortality who might benefit from implantable cardiovascular defibrillator therapy. We are very interested in the results of our TRAMI study. In fact, we studied to estimate BRS in our department in 1998. This photograph was taken at that time. Blood pressure was recorded non-invasively using tonometry. BRS was assessed using the phenylephrine method. BRS was calculated as the slope of the linear regression line relating the systolic blood pressure changes to the RR interval changes. At that time, many patients with type 2 diabetes were admitted for our department for education. So we evaluated BRS in those patients. This is one representative case. This is the ECG trace. This is automatically analyzed RR interval. And this is the arterial blood pressure assessed by tonometry. As shown here, when phenylephrine was injected, the blood pressure promptly increased. And in response to the increase of blood pressure, the heart rate slowed down. So RR interval is gradually increased. So in this patient, BRS was calculated to be 10.1, very preserved. This patient is type 2 diabetes with advanced autonomic neuropathy. So in this patient, although the remarkable elevation of blood pressure was observed, the heart rate did not change. So the computed analyzed RR interval is constant. In this patient, BRS was calculated to be 0.84, very depressed. We also evaluated in each patient MIBC scintigraphy. In this case, cardiac uptake of MIBG is well preserved, and HM ratio is pretty high. And the washout rate of MIBG was calculated to be 31, very preserved. However, in this patient with advanced autonomic neuropathy, cardiac uptake of MIBG is pretty depressed, and washout rate was 60%, very enhanced. So we reported the effects of essential hypertension on cardiac autonomic function in type 2 diabetic patients in 2001 JACC. In this study, 33 patients with type 2 diabetes were assigned to a hypertensive diabetic group or an age-matched normotensive diabetic group. This is the main results. When compared to normotensive diabetic group, the BRS in patients with hypertensive diabetic patients was significantly depressed. However, the plasma levels of norepinephrine and any indices of heart rate variability did not show significant difference. On the other hand, in MIBG scintigraphic analysis, the cardiac uptake of MIBG reflected by HM ratio was depressed in hypertensive diabetic patients compared to normotensive diabetic patients, resulting in the significant enhanced washout rate of MIBG in hypertensive diabetic patients compared to normotensive diabetic patients. So this is our conclusion. Our findings suggest that essential hypertension acts synergistically with type 2 diabetes to depress cardiac reflex, vagal, and sympathetic function. And this suggests that insulin resistant, although we did not, I did not show the detailed data, may play a pathogenic role in these processes. BRS and MIBG scintigraphy provide sensitive assessment of cardiac autonomic control in this population. Several years later, we reported follow-up results. Accurate follow-up information for 3 to 10 years was obtained in 184 patients. When the cutoff point of BRS was set at 6, the MACE-free ratio as evaluated by Kaplan-Meier analysis was significantly higher in the preserved BRS groups than in the depressed BRS group. This slide shows a detailed MACE, cardiovascular death, non-fatal myocardial infarction, coronary revascularization, stroke, congestive heart failure. So we concluded that the depressed BRS at baseline has long-term cardiovascular predictive value in Japanese patients with type 2 diabetes, without structural heart disease. Next topic is BRS in J-wave syndrome. In most cases of J-wave syndrome, I mean the Brugada syndrome and RA repolarization syndrome, ventricular fibrillation develops during midnight or in the early morning when parasympathetic tone is augmented. This phenomenon suggests that the modulation of autonomic nerves may play an important role in developing ventricular fibrillation in patients with J-wave syndrome. So we evaluated autonomic function in patients with Brugada syndrome and patients with ERS by MIBG scintigraphic findings and measurements of BRS. The study cohort comprises 28 consecutive patients with J-wave syndrome in whom ICD were implanted for spontaneous VF or syncope, possibly due to VF. So we included 20 Brugada syndrome patients and 8 ERS patients. In these patients, we estimated the cardiac autonomic function, including cardiac MIBG and BRS. They were seen routinely every month for clinical review and every 4 months for device check. The mean period of follow-up was 49 months. So this is the main and only significant results. As shown here, the patients with recurrence of ventricular fibrillation had a higher BRS when compared with J-wave syndrome without VF recurrence. When the cutoff value was set at 10, as shown here, high BRS J-wave syndrome had a poor outcome. I mean the high recurrence rate of ventricular fibrillation. So we concluded that the exaggerated reactivity of parasympathetic nerves as represented by increased BRS may underlie ventricular fibrillation in patients with J-wave syndrome. A final topic is BRS in atrial fibrillation. I would like to introduce our work recently published in Journal of AHA entitled Baroreflex Sensitivity in Patients with Atrial Fibrillation. It has been reported that AF may contribute to impairment of baroreflex sensitivity. However, difference of BRS between patients with persistent AF and those with paroxysmal form is unknown. So we tested the hypothesis that the patients with persistent AF have a more impaired BRS compared with those with paroxysmal atrial fibrillation. From October 2015 onwards, a total of 67 patients with paroxysmal and persistent AF who underwent catheter ablation were prospectively enrolled. The baseline BRS was evaluated during sinus rhythm. In patients with persistent atrial fibrillation, BRS was evaluated immediately after electrical cardioversion. This rise compares the baseline BRS value between paroxysmal atrial fibrillation and persistent atrial fibrillation. As shown here, the BRS value in paroxysmal atrial fibrillation was higher than that in persistent AF. So we evaluated the BRS before catheter ablation, after catheter ablation. This is all data, and this is paroxysmal, and this is persistent. As shown here, in patients with paroxysmal atrial fibrillation, BRS value was invariably depressed after catheter ablation. In patients with persistent form, in 3 patients, BRS was increased after ablation. So the mean decrease of BRS value is not so obvious compared to paroxysmal atrial fibrillation. So we calculated the BRS before ablation and after ablation. That is delta BRS. This is the results. In patients with paroxysmal atrial fibrillation, delta BRS was greater in patients with without recurrence of atrial fibrillation after ablation compared to those with AF recurrences. In persistent AF group, we could not find any significant difference between delta BRS. So we concluded that the baseline BRS was more depressed in patients with persistent AF compared with paroxysmal atrial fibrillation. The catheter ablation depressed BRS irrespective of the type of AF, with a greater effect in patients with paroxysmal form than persistent form. That's all. Thank you very much for your attention.
Okay. Doctor, thank you very much. Nice presentations. So do you have questions? Oh, Adrian, do you have a question?
I have a question.
Okay. Yeah, go ahead.
Wonderful presentation. I wonder, and then maybe Axel can speak as well, whether deceleration capacity, how it correlates with the changes in BRS. Because the capacity to decelerate is a vagal function in part. Again, I invite Axel to comment. So you have those data. It would be interesting to see, because it doesn't require phenylephrine injection. I would predict that deceleration capacity would correlate quite well with your BRS data. And that would be fascinating. You have those data stored, and you could examine this, because there are problems with HRT or limitation because you need premature beats for the most part. There are and with the BRS, the injection of phenylephrine is limiting in terms of practicalities. So it would be, if I'm correct, if deceleration capacity could be used here, this would be an important practical advance. What do you think? And perhaps Axel would comment.
Thank you for your comments. I agree with what you say. I'm sorry, I can't well understand the deceleration capacity. So, and in fact, I don't have any data for deceleration capacity in our patients. So, Takanori, please follow.
Yes, I think deceleration capacity that could be useful, but in Japan, that is not so popular. Most institutes don't have a software to measure the deceleration capacity. Probably only our institute can measure the deceleration capacity. so
maybe I could comment on this as well. Thank you very much, Richard, for this very important comment. First of all, if you like, we can calculate deceleration capacity in our lab on your data, blinded, and send it back just for your further interest. We would be delighted to do this. Maybe for an explanation for those who do not are familiar with deceleration capacity. Deceleration capacity is a method to condense the information of a 24-hour Holter recording into a very short signal, usually maybe 60 beats, preserving all periodic components. This means high frequency, low frequency, very low frequency components, and to look for oscillations related to decelerations and accelerations separately. And what Richard, I think, mentioned or suggested is that deceleration capacity, the periodic power of deceleration-related heart rate oscillations, is correlated or familiar with baroreflex sensitivity. I'm sure that it's related, but I'm not so quite sure that it's strongly related, because deceleration capacity is a tonic measure, while baroreflex sensitivity is a phasic measure, a reflex component. And deceleration capacity summarizes many influences of the cardiovascular system, not only the baroreflex, which is really obviously one part, but not all. It also captures the respiration variability, the very low frequency component, which has its own influences, even circadian variability is included. So, for instance, the 20-minute deceleration capacity, which is also a strong marker, is not really perfectly correlated to the 24-hour measure. So again, I think it would be very interesting to analyze the deceleration capacity in your data, to correlate it and whatever. We can do this. It's no problem for us. We can calculate we can also provide you the source code in MATLAB or something else. It's not protected. I'm free to share with you. I would be delighted to do this. And we can also do it for you and send you the markers back. But I guess it's something different a little bit, because it's another reflex measure. It's a tonic measure. On the other hand, it's also interesting that we calculated deceleration capacity pre and after catheter ablation of atrial fibrillation in Munich. It was published years ago, 15 years ago, in Heart Rhythm, 2006. And very similar to your data, we found that deceleration capacity was suppressed after catheter ablation, but then recovered very quickly. But 1 year after ablation, it was still depressed compared to baseline. But if I remember correctly, our interpretation at that time was that the immediate suppression of autonomic function after ablation might be influenced by some other things, such as the post-procedure phase of the patient, the bandage, and so forth. So when did you reassess baroreflex sensitivity after ablation? I didn't get it. Could you tell me how many days after catheter ablation did you assess autonomic function?
Several days after catheter ablation. So we are planning to re-evaluate BRS 1 year after the catheter.
Yeah, that would be very interesting. I guess there's still a difference, but it's smaller than directly thereafter.
I think it will recover. Thank you.
So longer after the ablation and immediately after ablation, the stories are much different. So you get both data. So very interesting and compares. Okay, so
Takanori, can I make a quick comment?
Okay, sure, Adrian.
So
please have a comment. Yeah,
I was trying to turn on the camera, but oh, there it is. So first of all, I want to congratulate the 3 speakers. I just got there at the end of Richard, but I enjoy a lot and learn a lot, because these are things that invasive EPs like me do very little. But what I wanted to reassure you, the 3 of you, is that the Journal of Electrocardiology, which is the journal of our society, has a full section dedicated to this, and papers on autonomic nervous system and associated with electrocardiology, with cardiac arrhythmias, with EP, from concept to clinical application, are super welcome. We have Richard helping us reading and qualifying those papers. And now we also have Tolga Aksu from Turkey, who is an invasive EP doing ablations and cardio-neuroablation. So an invitation for the speakers, of course, because each one of those topics could deserve easily a mini review in the journal. So even if you have published this in JAHA or in other journals, every concept of that, making it easy and digestible for people like me that is not practicing what you do, it could be highly desirable. So just to say hi to everybody, an invitation and a refresh your memory that the journal will be delighted to receive your papers, your cases, your mini reviews. Thank you both for to all of you. Thank you.
Okay, thank you, Adrian. I think in my impression, if we combine the three of these markers, that is a very, very strong risk stratification markers. Okay, so no comment or questions? Okay, we learned a lot of things from three distinguished speakers. I would like to say thank you very much to attend this webinar. I will close this webinar. See you soon. Bye.
Bye.
Everybody, bye.
Bye.
Bye-bye. Thank you very much
Bye-bye.
for all the speakers.
Okay.